Hello, I'm Donal Macaulay and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Australia and I'm talking to Paul Glasziou. Paul, tell us about your current role and a little bit about how you got there.
So my current role is as the director of the Institute for Evidence-Based Healthcare at Bond University. And I came here about 15 years ago with a thing called an Australia Award, which is it's like winning the research jackpot. They give you your salary, plus they give you some research money to use. I've had to then since renew that sort of thing, so re-applications as is usual in the research world, but therefore mostly doing research work. I do a little bit of teaching still, particularly in evidence-based medicine. I haven't done clinical work as a GP since I left Oxford in 2010. So this was my sort of retirement trajectory.
Well, I think most of the people watching this will be thinking, I'd really like to win that jackpot. I mean, what an achievement. That is fantastic. Let me take you back to Oxford. That was a really unusual, remarkable, pivotal period in your career. Tell us about that.
Yes, so I took over the Centre for Evidence-Based Medicine in Oxford, but also a position within the Department of Primary Care with David Mant. That was in 2003. And that was largely, again, to do research work, though I had quite a greater responsibility there for teaching, particularly the evidence-based medicine in several streams, but also of taking over the work that Dave had developed in terms of trying to teach the next generation of teachers of evidence-based medicine and researchers in that area. So particularly important, for example, was there was an annual 5-day how to teach evidence-based medicine workshop at which we'd have 50 to 100 people. A lot of fun to do, I must admit. Pretty unstructured. So, people would sort of decide on their own agenda. So it was different every year, which made it even more fun for people like me. And just such a diverse group of people from around the world, many of whom I'm still in touch with. So that was an absolutely fantastic period, particularly focused on teaching, but also emerging areas for me of new areas in evidence-based practice.
It must have been really terrific bumping into so many of those experts. Tell me about some of the people you met and the influence they had in your career.
Yeah, Oxford is just such a wonderful place to be because you've got so many of the world leaders in every area of research, generally of science, but obviously particularly healthcare. So medicine is such a large component of the Oxford group, and of course I ran into Dave. Came and visited a couple of times, and Sharon Strauss, who was Dave's protege while he was there. But obviously the people within primary care, like David Mant, who'd really built the department up to be one of the strongest departments, which has continued to grow since he retired in primary care in the world. So that was fantastic. I got to know Ian Chalmers, who I'd met a couple of times previously, but Ian, as you probably know, after he'd started the Oxford Database of Perinatal Trials as a sort of pilot run, then kicked off the Cochrane collaboration in roughly 1994. That was developed by another great character there, and that's Sir Muir Gray. And Muir was responsible for both the funding of the Centre for Evidence-Based Medicine and getting Dave Sackett to come over from Canada, but also recognising Ian's idea of trying to have this global collaboration for systematic reviews, and so funded the UK Cochrane Centre initially, which then took up other sources of funding. So Ian I still stay in touch with very, very regularly. He's now retired, but still an absolute live wire. And then just lots of other people around Oxford. I could probably think of Peter Rothwell, who's a neurologist there, who's a particularly incisive character who's made some really major developments. Interestingly, outside neurology, I think Peter's probably most famous for finding that aspirin is useful to prevent colorectal cancer. So Jeffrey Aronson, another fantastic character there, clinical pharmacology, and he's such an incisive thinker, an encyclopedia of virtually everything, but particularly pharmacology. So that's just to name a few of the characters I met there.
Oh, an absolute galaxy of stars. It must have been such a fertile place for thinking and creativity. Now, you also, I believe, did you have some relationship with Stanford?
Not a strong relationship, but there are a couple of people there like John Ioannidis and Steve Goodman, who are involved in the whole area of sort of meta research. And there was a paper that Ian Chalmers and I had written in the Lancet in 2009 about the 85% waste in research, avoidable waste. And so some of the people from Stanford, John in particular, became involved in a longer series that we did in 2014, looking at breaking it up into more detail and documenting where that research waste was occurring and how we might fix it.
Now, let me bring you back to the evidence-based medicine, because evidence-based medicine became almost a religion with evangelical believers. But I think you also accept there are some limitations to evidence-based medicine.
Of course. I mean, the general idea of evidence-based medicine is almost a no-brainer. It's that when we're making clinical decisions, wouldn't it be great if you could have the best evidence available to inform your decision? Gordon Guyatt, who coined the term evidence-based medicine, really was looking for a way of trying to highlight a difference in the residency training that he was doing at McMaster. But if I had the time again, I probably would have called it evidence-informed medicine. And there's lots of different evidence that you need to inform clinical decisions, but certainly that includes randomized trials, but it's not exclusively randomized controlled trials, which is a common error and myth, I think, that people make.
Now, the other thing about evidence, and you mentioned research waste earlier, can we have too much evidence?
You could have too much poor evidence. So if it's scattered and not pulled together, then it's really the scattering of the evidence actually makes it harder to find the evidence that you need and to make decisions. And that was really Ian Chalmers' idea of, well, let's try and pull it together in one place and have it synthesized. So he's got a lovely quote from the 1800s, which try to remember the president of the Royal Society, I think it was at the time, who said that science consists of these two processes of the individual pieces of research and discovery, and then of the synthesis of all of those individual pieces. And the two pieces go hand in hand. If you didn't have that second component of synthesis, it would be just like having this pile of boulders, but not a nice rock fence. So you need both the boulders as the material, but then you need the rock fence as well. And that needs a careful selection of the various pieces of evidence pieced together in a thoughtful way.
The next kind of problem we have then is, how do you persuade clinical colleagues that clinical trials are important?
Okay, so can I say two things this comes from my time in Oxford. One is I remember being a bit depressed about, the long time it was taking for evidence-based medicine to get into practice. And I remember Tim Lancaster, who was in that primary care department, saying, look, Paul, the conversation has changed. You can't now have a clinical discussion about policy without people raising the idea of evidence and that not being controversial. And Tim was right, and that's become truer over time. If you talk to the younger generations in particular, it's just such a natural part of the conversation now. It's not evidence obedience, but people would want to know, well, what do we already know about this from the research? Right, so that was quite a change, I think. The second part is, I think you and I in primary care have this sense of we would like to see more research happening in primary care, but it's not true of all medicine. So one that really struck me was Bob Phillips, who used to come down for the evidence-based medicine workshop. He's a pediatrician who became a pediatric oncologist. He was saying that in childhood cancer, his principal area, doing trials was just the way you did business. Most children with a cancer were either enrolled in a trial, that's how they were being treated. They were comparing the current standard with the possible better version, right? They were either doing that or they were using the protocol that had came from the winner of the previous trial. That's how you did all. Now, wouldn't it be amazing if all medicine was like that? It was just the way you did work. I think that's increasing. I would say ICU people, the ICU networks I know have that's become pretty routine, that most people in ICUs are in trials now. So there are areas of medicine where it's changing. And I'm very sad to say that I think general practice primary care still is nowhere near that. We're improving, particularly in the UK and the Netherlands, I think have been global leaders in that. But the proportion of patients in primary care that are in clinical trials is so small at the moment. And we really need to learn to change that. But I just wanted to point out that's not true of all of medicine.
One of the other areas that you're interested in, and it's a kind of an evolution from the evidence-based medicine, is the idea of overdiagnosis. And I think I think I heard you say that you think everyone should buy their spouse a CT scan.
Only if they don't like them. Yeah, in fact, I just published a paper with a physician from Brisbane called Ian Scott on incidentalomas, which is the problem of buying your spouse a CT scan. Is the average is something like, I don't know, between 1/2 and 2 incidentalomas per CT scan that you do. And they're becoming an increasing problem of occasionally they'll save a life, but mostly they'll lead to additional investigations that may harm the person. And incidentalomas are just one part of overdiagnosis. I think there are probably 2 major areas. One is discovering those things that we don't know what to do about, and that's incidentalomas in routine investigations, even more so in screening. But the other is our expanding definitions of disease. And this was really brought up to me by Ray Moynihan, who was a PhD student here, but a journalist prior to that who'd been working in too much medicine with the BMJ. So you may have come across him with that area in the BMJ. And so Ray was really interested in how all the definitions of disease changed. And one of the most extraordinary things is we have rules about how you name dinosaurs. You know, there's a global committee for that. There isn't the equivalent for naming diseases. It's just people just invent a disease. And Ray showed how easy it was. He developed this thing. There's a wonderful video that you can Google called motivational deficiency disorder. And it was this spoof on how easy it was to create a disease. And Ray had a severe case, but fortunately a neurologist in Newcastle had discovered this new treatment for motivational deficiency disorder, etc. I won't spoil the rest of it. It's just a wonderful video to watch. But it is a real problem. So one of the areas that I'm working on at the moment is gestational diabetes. So I'm not sure if you're aware of the controversy there. There was a change in about 2014, which roughly doubled the number of women being diagnosed with gestational diabetes, depending if they adopted that new criteria or not. And we've now had a spate of randomized trials, the first by the Kaiser Permanente group in the US, and a couple of others that have occurred now that are really showing that there, for those extra cases diagnosed, that there's no benefit.
So you've brought us up to date with some of your current research. Tell us a little bit more about what you're doing at the moment and what you're interested in.
I'm getting near retirement, to point out. I'm going to continue some things that I've been sort of thinking to pick and choose amongst them. What do I actually want? And probably the 2 major ones are, we need to revise the checklist that Jenny Doust and myself and several other people were involved in for the Guidelines International Network on how you define a disease. So we've got this 8-item checklist. that's been pretty useful, but having used it now a bit, I can see we would like that to be a better checklist and to be more widely recognised. So Jenny's been talking to WHO in particular about being involved in this thing so that we get up to the dinosaur stage, at least, of having an international committee that can help decide on what the definitions of disease should be and who the committee is formed by, so there's no conflicts of interest in people deciding on diseases. So that's number one. Number two is I've been very interested, largely because of the evidence-based medicine journal that I was editing, that I took over from Dave Sackett. And in that, I would often see non-drug treatments. So evidence-based non-drug treatments like the Epley manoeuvre that we all know and love for treating benign positional vertigo, but all sorts of exercise, pulmonary rehabilitation, avoiding peanuts when you're young to prevent peanut allergy. There's so many good non-drug interventions, but they're not promoted. Unlike drugs, we don't have a good marketing body, and nor do we have a non-pharmacopoeia. Well, we didn't. College of GPs had agreed to the idea of developing one. So we now have a thing called the Handbook of Non-Drug Interventions, which is evidence-based non-drug interventions. The rule is you have to, like the FDA, at least 2 controlled trials or preferably a systematic review showing evidence of benefit. And so I would like to see that further develop and internationalize so that every doctor around the world, particularly in primary care, had access to a non-pharmacopoeia that sat beside their pharmacopoeia, would be my dream, and that they pulled it down just as often for using effective non-drug treatments. So they're the 2 big things that I want to continue with.
Listening to you talking about evidence-based medicine and realizing the enormous influence you've had on the academic progress in primary care, people could be forgiven for thinking that you're a really deadly serious academic. But actually, I know you're known as a surfing professor. So tell me a little bit about the things outside your life, your surfing, and of course about our dear friend Chris Delmar.
So Chris, as you probably know, had a surfing accident, unfortunately, about 4 years ago, and was not surfing after that, and passed away about a bit over a year ago now. So that was very sad to see, because Chris and I used to go surfing regularly. So I'll tell you an interesting story. Because we live in the same street, we used to go in the same car together early in the morning. We'd get together, put our surfboards up on the top, and go down to a place called Currumbin Alley and surf together. And because we were 2 blokes that always arrived together early in the morning, a lot of people thought we were a gay couple. And I didn't discover this for quite some time, when one of my friends just asked me about, how close are you and Chris? And we were very close, but not in that way. So I miss him a great deal. He did great things for primary care. I think really raised the profile of primary care, was so passionate about antimicrobial stewardship, but was just an all-round good bloke as well.
Paul, thank you very much for chatting to us this morning, and thank you very much for your immense contribution to our profession. It's always wonderful to talk to you. Thank you very much indeed.
That's been a pleasure.